I think Madam is with us, and you can start taking questions now.
Okay, I'll just start off the first question. I'll put in two parts. The first question is, when would you advise aortic root enlargement?
I can't
What I will do is, I'll ask Dr. Sheetal to elaborate on that from the echocardiographic point of view, and I'll also ask the surgeon, Dr. Bashi, to give the second part of the answer from the surgical point.
The usual decision for aortic root enlargement is made almost always after going on bypass. We can make out is a very small annulus, compare it with the body surface area, and when we feel that the aortic annulus is very small, which may require a smaller aortic valve and may result in the patient prosthetic mismatching.
Sir. Yeah, I can, but you can't. Hello, can you hear me?
Yeah, we can hear you, ma'am.
Answer the question. Then
can you hear me?
We can hear you, ma'am.
Yes, you can hear now. Okay, fine. Dr. Sanjeevani Namdar wants to know from Dr. Santosh, what is the deciding fitness and risk stratification before AV replacement? Is LVEF is enough, or you would like to know more from TE?
TTE, I think.
Yes.
Because to decide fitness, we have to do transthoracic examination before we take the patient for surgery. So basically, I think she is asking to know about how to proceed if the patient has a low ejection fraction. This is a low output, low gradient scenario. So it is important to identify the patient if the patient really has a true aortic stenosis or not. And secondly, whether the LV will be able to tolerate the aortic valve replacement surgery if it is done. So to do that, you have to consider dobutamine stress echo, and you have to measure various parameters. Three important parameters are: look for aortic valve change with the dobutamine stress echo, and look for gradient, whether it increases or decreases, and look for the stroke volume. If the stroke volume increases at least by 20% with a gradient more than 40, I'm talking about mean, and without any change in the valve area or reduction in the valve area, then these are the patients who will do well after the valve replacement surgeries. Otherwise, other set of patients usually have a myocardial fibrosis. They generally tend to do poorly following surgery.
Okay. Then Dr. Muthukumar Rajagopalan, he wants to know, is it possible to guide the surgeon for cannulation of aorta through lumen when there is dissection using TE? So which view will be taken?
A lot of times it is possible. So what we are going to see is both the views, either short axis and long axis view. And actually, when we try to assist by echocardiography, we will start it right from the guide wire. So a lot of times you can see the guide wire, which if it's going into the true lumen and false lumen, of course you should be able to identify correctly which is true and false lumen with the previous criteria. And then after the guide wire, then when's the actual cannula goes in. So we do put it in a lot of times as it becomes like a normal reflex. If they are trying to pass the guide wire, we quickly focus our echo images to look into that view.
Okay, fine.
Okay, Manjula, can we request Dr. Bashi, who is a surgeon here, to tell us something about what is the surgeon's perspective for aortic surgery and aortic valve surgery when it comes to TE? What are their expectations, surgical expectations? Can I do that, Suresh?
Yeah, please.
Because we have very experienced surgeon.
One of the most famous surgeons doing aortic surgery.
Right.
We would like to know more from him regarding that Evita frozen trunk, which is now, I'm sure he has done quite a few cases. We would like to know more about it, how he goes about it.
Yeah. Now, first of all, I must thank Murali for organizing such a fantastic meeting.
And I congratulate all the speakers, Dr. Sudhakar, Dr. Santosh, and Seetal, for presenting and elaborately educating. In fact, I have learned more than what I'm going to talk to you, because it has been so nice, and educating all of us in echocardiography is a very big advancement in patients' results. Coming to one question, I will answer 2 or 3 questions. One question was aortic root widening. Aortic root widening is usually basically a surgical decision, depends upon the age of the patient, the activity of the patient. Younger patients come with aortic root narrowing, definitely needs widening because they have to live longer. Very old patients, normally we don't do, because it is definitely technically demanding procedure. It has got its own risks and advantages. So when surgery is experienced, amount of aortic work, and you should definitely avoid a prosthetic mismatch. That is number one. Number two is transesophageal echo definitely has helped a lot in the management of aortic dissections. There are situations where even CT angiogram will not be able to. I had a couple of cases where CT was not able to point the point of entry in the ascending aorta, and they say there is no entry point. And when you do put a TE, definitely you are able to make out the anatomy, especially the aortic incompetence. We have to have some idea about that. And then regarding cannulation, aortic cannulation, usually in aortic dissections, most of the centers in India, and most of the developing countries, they do peripheral cannulation only. Central cannulation, as such, I don't do much because it's a very expensive cannula. We can, usually the lesser curvature of the aorta, if you puncture under TE guidance, usually that area will be the true lumen. No, most of the time, 90% of the time, in the greater curvature of the aorta will be the false lumen. For some reason, the true lumen will be there. You puncture under TE guidance, pass the guide wire, and do a Seldinger technique, and pass the cannula into the aortic arch. In the US, most of the centers, they do direct aortic cannulation because that's the fastest and easiest, because most of the aortic surgery is done under circulatory arrest in many of the centers, aortic dissection, acute dissection, because we have to do an open arch technique without putting a clamp. So circulatory arrest is necessary. Once the circulatory arrest is there, you remove the cannula, do a grafting, and put through the side branch, you perfuse. That is number two. Then the question of Dr. Murali only asked me about the frozen elephant trunk technique. That is also, he definitely has a very big role. We almost do about almost one case a week nowadays. Actually, I had one case last week. Next week, I have one. COVID, we have done about 6 or 7 cases with this Thoraflex graft. In that, normally we do, cannulation usually depends upon peripheral cannula, either axillary artery, femoral artery, or carotid artery we cannulate, or sometimes innominate artery if it is not dissected. And then the present graft, usually the other graft, the indigenous graft which we have before the elephant trunk graft was available, we usually used to pass a guide wire after the patient is positioned and through the true lumen, because you cannot put the graft into the false lumen, it will be very difficult. So now with this present graft, you can see the true lumen. When the aorta is opened, the graft just slides into the aorta, descending aorta, and then it can be opened. So the guide wire problem can be avoided. One thing I want to tell you is that if you are using guide wire, stiff guide wire, especially the intricates wire, definitely you must give heparin the next minute, because I had 1 or 2 cases in the beginning where we forgot to give heparin. When we opened the aorta, we found the blood clot through the whole of the guide wire. Fortunately, nothing happened to the patient. So it's a very important point. If you are putting a guide wire, definitely patient has to be heparinous, especially the stiff wire. Then another most important thing of TE is once you, of course, we have to study the TE, the CT aortogram. 0.5 millimeter we analyze, especially when you do idea. So first is to cover the major point, which is distal to the subclavian. Then there may be minor entry point, and all those cases we have to cover the smaller entry points. Otherwise, aorta can dissect distally. The smaller the entry will become bigger after the graft is put. So once the graft is put, the TE definitely helps to find out whether the true lumen is the false lumen is thrombosed or still it is active. I have 1 or 2 cases where when we put one graft, The false lumen pressure was so high, almost the graft was getting compressed. So under TE guidance, we deployed another graft into the descending thoracic aorta and covered the distal re-entry point. So it's really a tremendous help for us to assess the patient in descending thoracic, especially when you do the frozen elephant trunk. Then regarding the question asked for about for aortic valve repair, that is another question I was asked, no, about to comment on aortic valve repair. Definitely, that is a very, very big help for us, especially once we release the cross clamp to find out the, see, like namaste sign, that's we call it. It should be like a namaste. That is the best coaptation height for a competent valve. And once you are happy with that, only aortic valve repair is not like a mitral repair, because mitral repair is little more easy. Aortic valve repair, if you don't do a good repair, residual AR, patient will have to pay a price for it. And if somebody has to have a valve replacement within 6 months or 1 year, there's no point in doing a repair. It should last minimum at least for about 10 years. And the status of aortic valve repair in India today is mitral valve repair about 30 years ago. And our younger surgeons are getting experience, especially with the help of TEE. It is going to be a very big lot of cases we will have for aortic repair. I would say about 70% of the valves replaced today can be repaired with the help of our colleagues. You know, like what you are doing now. It's I must reiterate the fact that this echocardiography has really revolutionized the stress for us intraoperatively and postoperatively. We can go home peacefully. You see what is happening in the valve, so that you don't have to worry about it. So thank you very much. If any more points, I was talking in a hurry because lack of time only.
Thank you.
Any other questions?
Dr. Keshav Murthy also. Is he there? Dr. Keshav Murthy?
Thank you. Thank you very much for your comments, Bashi.
Yes, sir, very much.
Appreciated.
Yeah, Dr. Keshav, I just want to know from your side, your perspective regarding valve.
Sir, I am anesthesiologist, not surgeon.
Keshav Murthy is my colleague, consultant anesthesiologist.
Okay. See, one more question I would like to ask is, I don't know who exactly is asked. This is in relevance to TAVR. We can easily measure the distance between the aortic annulus and the right coronary artery. Is there any way to measure the distance between the annulus and the origin of left coronary artery? Anybody can take that question. Rupa, you're not audible.
Rupa, please switch on your mic.
Can I answer by that time?
Let Rupa answer. She's panelist.
Yeah. I mean, there's some issue in our audio.
Rupa, can you unmute yourself? Can you?
Okay, Rajesh, you can. Any of the other panelists would like to answer the question?
Rajesh is asked, so let Rajesh reply.
Okay, fine. Please go ahead.
I think in the aortic wall long axis or LV long axis view, we put the color on the anterior part of the annulus, close to the anterior part, and we can see the origin of left main artery. And from that origin, we can measure the distance from the aortic annulus. And normally we have seen the patients who have got dissection, type A dissection, ascending aortic dissection, if the origin of the dissection flap is at least 1.5 centimeter above the origin of left main artery. If the origin of flap is above the left 1.5 centimeter above the origin of left main artery, definitely we can try saving the aortic wall and just go for the root replacement. That's what has been tried at our place, and we have been very successful for that.
Okay. Any other questions from the panelists? Any suggestions or comments from the panelists? We are running out of time. Dr. Jayaprakash?
One or two comments, please.
Yes, sir. Please.
I think Sheetal missed out on the point that there is a blind spot in the aorta, which I think we did not mention.
Yeah.
Part of the ascending aorta, which lies in front of the
right trachea,
and where if you need to examine that part of the aorta, you may have to use aortic scanning.
Yeah,
the
correct.
Other thing I wish to mention is that for considering the aortic dilatation, you mentioned about 5.5 centimeters and above. So nowadays there is a tendency to index this the aortic diameter in order to take a decision about the replacement, because in a smaller size patient, even a diameter of 4.5 would warrant aortic root replacement. About the aortic regurgitation, I wish to mention that somebody asked about the timing of the valve replacement. It's a very relevant question. In our country, it does not matter because most of the patients present at a very late stage. But if you really need to time the aortic valve replacement, you need to know when the left ventricle has started failing. And as per the present guidelines, the LV end systolic diameter of 5 centimeters is taken as the cutoff for replacing the aortic valve in presence of aortic regurgitation. This diameter used to be 5.5 centimeters. It has now been revised to 5 centimeters. So if end systolic diameter of LV is more than 5 centimeters or is at 5 centimeters, the LV failure has already started. Thank you.
I have one comment. If I want comment
Yes,
and one
yes.
question to all of
Yes,
you.
please. Yes,
The
please.
comment is regarding the diameter of the aorta. It is a very difficult thing in the sense. I think we have to put. See, when you open the pericardium, you find the blood pressure is good. Aortic diameter is definitely at its maximum, and the moment you go on bypass, aorta size will just become so less. So it's very difficult to assess the diameter of the aorta on the table to take a decision what is the ideal thing. So one has to really do the pre-operative assessment of the aorta both by CT as well as echocardiography. So I would suggest, one of my suggestions is whether somebody can do a study and find out what is the correlation between the CT aortic diameter as well as the echocardiography assessment. Why I am telling you is it's very important in follow-up of patient. For example, we do a patient with the surgery, and if the aortic diameter is increasing, if you can do a TE, or it saves a lot of time, money, and radiation to the patient. So most of the time I go by, a good echocardiographer to follow up the patient. Every time you cannot do this thing. Second, the question I want to ask is, it's if anybody can answer that question, is because at least about 10% of the time when I open up for aortic valve replacement, I find especially in bicuspid valve, you say diameter of aorta is maybe 4 or 3.54, doesn't need any replacement. But when you open the aorta, give cardioplegia, you find that aortic sinuses are very thin. Definitely patient will need a bendor. This is neither seen in echo nor seen in a CT aortogram. Is there any way you can document the thickness of the aortic sinus? That is just above the annulus. The aorta is very thin. When you open only, you see that. So I have asked many cardiologists, echocardiographers, they all say it is extremely difficult to predict the thickness of the sinuses in that area, because if the sinuses are very thin, one do a valve replacement, definitely patient will come back with the progression of the aneurysm within years or not even months sometimes. So it's a very important area to be looked into, whether you can give us some insight so we can plan, because especially a person who is starting to do aortic root replacement, to get a surprise on the table is not a nice thing nowadays.
Thank you for those 2 points. So I think we need to look into this problem more closely about the diameter of the aorta, pre-operatively and intraoperatively with TE, and compare them with the CT findings. That's a very excellent suggestion. I think we'll take it forward, and sometime we'll give this a project to one of our DNB cardiac anesthesia fellows or DM cardiac fellows. So, and we will get it done. And the second point also, I personally do not know about this, how to predict thin sinuses. I think we need to have
Is there another mic sign?
Another study for that to look into this thing. Rupa can tell something on that? Rupa Sridhar?
Yeah, am I audible?
Yeah, now you are
audible. Am I audible?
Yeah, now you are audible. Can you tell something about these 2 points? About the diameter of the aorta before surgery and during anesthesia, they are different. So do you have any comments on this? Rupa, come on.
They are not very different. Yeah. about the diameter of the aorta is there is a difference, but they are not so very different. I would
But
like
have
to
you seen it? Has anybody measured it?
no,
Yes, we always measure,
study.
Dr.
No, preoperative versus intraoperative. I'm talking about that.
There is always a difference between the preoperative transthoracic echo and the intraoperative because the hemodynamics is different. The patient is not spontaneously breathing, he is on mechanical ventilation. So we need to have normative values in that respect for all the measurements that we perform.
But is it documented?
Yes, there is always
and also,
no, is it documented?
And also, it also depends upon the blood pressure of the patient. For example,
Yes,
you assess the diameter of the aorta with about 80 millimeters pressure or 140 millimeters. Definitely, it will be different. I can tell you that. From visual itself, I can see
Yes.
the moment we go on bypass, aorta just shrinks. PP40 aorta just becomes half the size. Then another thing also, now all our studies are being done like everywhere. It is like all based on Western statistical studies. What is the normal aortic? In fact, I am trying to get some study to find out. You analyze maybe over 1,000 echoes of normal aortas. Patients may be coming for coronary bypass surgery or does not have aortic disease. What is the mean diameter of the aorta in India? Because say 5.5 is the diameter for aortic ascending aortic replacement in the Western countries. We are much smaller than that. Our threshold may be low, but still we are in the darkness as to what is to be done ideally, because no studies have been so far. I think you can take you have got a big role in because so many cases are taken.
So may I interrupt 1 minute? The question is, what you're talking about is the thickness of the aortic wall. We are not looking at the You're talking
two things I am talking. Thickness in the aortic sinuses especially.
Yes,
because ascending aorta, you get a thickness when you do the sick. Whereas when it comes to deep down, that when the sinuses dilates and becomes thin, it will be very thin. When you open only, you can see. Especially when you give surgeons can definitely see that. It's a very thin membrane like things. And if you leave like that, it can dissect later. So those patients definitely, on the table, we have to do a Bentall's procedure. A surgeon who is experienced to identify that. Otherwise, they will get away with a valve replacement and patient can have a dissection. The second thing I was talking about, to do a prospective study on the diameter of aorta in our patients, because all of you put together can compile. For example, say you do 1,000 or 2,000 echocardiograms a year. This is not related to aortic disease at all. To come at a statistic to find out what is the age group. I don't know how to do the study. Probably you can find out what this will be a good thing because you all are doing this.
So there was an attempt by one of our colleagues to study all these parameters in non-cardiac, normal patients undergoing non-cardiac surgery. But I don't know how far that has reached. We'll have to revive it. Thank you, sir. Then one more
to Dr. Bashir's query. One of our colleague, Dr. Sridhar Joshi, has answered that this study has already been conducted and it is published in Journal of Thoracic Cardiovascular Surgery in 2019. A comparison between the aortic root measurements by echocardiography and computer tomography.
But what we are interested is anesthetic condition and awake condition.
No, the study was conducted under anesthesia because we had to pass a TE and actually measure it. There's a question from Professor Minati for Dr. Santosh. In a severely calcified aortic valve, for size assessment, you personally prefer a 2D or a 3D?
Actually, I don't do 3D, a lot of 3D, but with experienced hands, probably the assessment of size will be
one more question. I think this is the last question I'm going to take. This is about paradoxical low flow, low gradient. Somebody can answer that? How do you differentiate? Do you do a dobutamine stress in these patients and identify what is happening? And also along with that, I would like to ask, most of these patients with aortic stenosis also have severe grade 2 or grade 3 diastolic dysfunction. These patients may actually produce a lower gradient, low flow, low gradient. What do you do with these patients?
I think that question was just now discussed, sir, just 5 minutes before.
Yes, saying, what do you do? You still do a dobutamine stress?
Yeah, you have to do dobutamine stress echo just to find out whether the patient, to divide that patient group into two groups. Like few other patients, one subgroup will have a severe aortic stenosis with severe LV dysfunction. In such patients, dobutamine stress echo is likely to improve the stroke volume and as well as increase the gradient. So if the gradient doesn't increase or stroke volume doesn't increase and valve area remains normal in the sense it's same or reduced, then you can say this patient is probably having a myocardial fibrosis. These are the set of the patients who don't do well after the surgery. And if the valve area actually increases, the aortic stenosis that is measured by planimetry was actually false. So these patients probably do not require a aortic valve replacement or a dressel.
I think we have run out of time. Rajesh, shall we stop or you want to continue for some more time?
No, I think we can go to the next session because all these questions will be sent to the panelists and the speakers individually by email, and they can answer these. They can reply the answer by email to the individual person on their email.
Then let me thank all the panelists who have come for the evening as well as the speakers. Excellent discussions we had. Thank you all for the evening. Thank you, Dr. Manjula also.
Yeah.
Thank you so much.
Thank
Thank
you.
you so much. It's my personal thanks, gratitude to all the panelists, especially Dr. Bashi, Dr. Rupa Sridhar, Keshamurthy, Jayaprakash, and Raghu, and the moderators, Dr. Suresh Nair, Manjula Sarkar, for having been with us to conduct this session on aorta and the aortic valve. Very well done. Thank you so much. We would like to continue to be associated with you. Please contribute to the growth of knowledge in both the youngsters and the practicing anesthesiologists. Thank you very much. With that, we'll conclude this session and we'll go on to the next item in the
Thank you, sir.
agenda.